وين مسعد؟ مسعد سماعات وين؟
Hi, greetings, Dr. Sbeih. Hi, Dr. Sbeih.
Hello, John. How are you?
You can hear me okay?
Yeah, I can.
Okay, very good. Very good. So how you been?
All well.
Let's see, virtual audience. Now that's it. You have an in-person meeting there in Jordan, or is it just you and the consultants?
I did not get that, John. Come again?
Is it in the room you're in? Is it you and the consultants, or you and some students, or they're all virtual?
The audience here in the room, mixture of various things, residents and consultants.
Oh, okay. Let me change this. Yeah, we start in about 5 minutes.
So,
Good time. There's a neurosurgeon here that wants to come do a fellowship with you, not a fellowship, but
yeah, she sent me a letter and I will
have you met Nargiva? How you doing?
Good evening, sir. Good evening, Professor. I'm
Good evening.
doing well. Thank you so much.
Yeah, I'd like you to meet Dr. Sbeih. He's the man.
Yes. It's my pleasure and honor to meet you, sir. I'm very happy.
Nice to meet you. Thank you very much.
She's from Uzbekistan,
Yes.
Yes.
currently in Turkey, right?
Yes, doing my pediatric neurosurgery fellowship.
And you're interested in being with Dr. Sbeih for a month or two?
Yeah, I would like to come if I get any chance, at least first for 10 days, maybe, and later on plan for a longer period. So
Thank you for your letter, and I will answer you appropriately, inshallah.
thank you so much.
Okay, you got his contact info, right, Nargiva?
Yes.
Okay.
Hi, John.
Hey, Dr. Hashad, I know everything's going to be all right if you're here.
I'm just waiting to listen to Professor Saleh. He's a good speaker.
Are you at
How are
home?
you,
or-
Hashad?
Yeah. Hashad, are you at home or in the hospital? Oh, he may have stepped away. That answered my question. He's probably in the hospital.
Hi. Hello.
Yes, hello.
Just looking forward to listen to him, Professor Saleh.
Thank you,
Okay.
Hashad. Can you put the video on?
Yes, yes.
I cannot see it.
I've been very regular in your Jordan classes rounds and on the webinar also. Yeah.
It's a pleasure to have you.
Yeah. Enjoyed your all meningioma talks earlier and gliomas and everything many times.
Thank you for being with us.
Great to hear. Looking forward.
Thank you.
What is your topic today?
It's about the choroid plexus papillomas.
Oh, wonderful. Wonderful.
Yeah, let me get the let me get it, show you Harshad. You see the topic there, Harshad?
Yeah, I can see it. Yeah.
Choroid plexus pathology stressing on
Papil-
choroid.
Yeah.
Okay.
Wonderful. Wonderful.
Okay, Dr. Sbeih, why don't we start? Because the people will be coming as we go along.
Okay.
Okay?
نادي
Okay.
مصعب ولا لا نادي مصعب.
You want to start or you want to wait? What do you want to
Just
do?
couple of minutes.
To start in a minute or two? Okay, no problem.
Couple of minutes.
Okay. No hurry.
Thank you.
Nargiza, I'd like you to meet one of our attendees and one of our best students, Harshad Parekh from India. Hello,
Good
Harshad,
evening.
say hello to Nargiza, a neurosurgeon from Uzbekistan.
Oh, right. Great to know you.
Good
I
evening.
believe, yeah. You are doing your fellowship where?
Right now, I'm doing my fellowship in Istanbul, but
Istanbul.
I have been
Oh, right.
staying, yes, in India, in Maharashtra for almost 3 years. So I was previously the fellow of Ibrahim, and we are
Oh,
just,
Iberian. Okay.
yes, keep going and working together. So
Karad, you were in Karad.
yes, I was in Karat. 2 months back, I was there.
Just met Cherian 2 days ago in
Jaipur.
Jaipur conference. Yeah,
Okay,
he was
yes.
there. Yeah, in Meninjoma conference, he was there.
And-
Good. He's doing a great job.
and,
Great.
well, this-
Istanbul had a conference recently.
Yes, Rotten Society
Fitting
meeting
position. Yeah.
was very big and beautiful.
Yeah. All stalwarts there. Yeah. Right.
Yeah, she saw one of Dr. Sbeih's talks and now she wants to do some time fellowship with him.
Mm. Yes.
This is the best time to visit people and learn and observe them. And it's a wonderful time.
Did
At
you
this age.
travel at all, Dr. Parekh? Did you travel other parts of the world during your residency or before?
Yes, I did. I
Where'd you
went to
go?
Zurich. I went to England. I was in the US. I was in Zurich with Professor Yasser Gill. And quite a lot of, during my residency, I was there out of town.
Yeah.
Good time.
We are ready to start.
Okay. Can you get off the screen, Dr. Sbeih, so I can
Sure.
see your face before we start, please?
Okay, we'll do.
Okay. So people can see you before they start. To give you a proper introduction. There you go. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, beautiful Miami Beach. We have another Jordan Neurosurgical Grand Rounds with Ibrahim Sbeih, a well-known neurosurgical educator from Amman, Jordan, who does a very good multidisciplinary webcast. You don't see that many on the web. So we look forward to this. Okay, Dr. Sbeih, it's all yours. And thanks for coming.
Thank you, John. And on behalf of my colleagues here in Jordan, we welcome you for this webinar coming from Farah Medical Campus here in Amman, Jordan. All right, so the topic is cerebellopontomedullary choroid plexus papilloma, which is a very rare site for the choroid plexus papilloma. And as usual, we will discuss it from the clinical radiological.
So it's not moving?
We will discuss it as usual from the clinical radiological, operative, and pathological point of view. Choroid plexus can be anywhere, of course, in the ventricular system. This is the lateral ventricle, this is the third ventricle, this is the fourth. So choroid plexus is present in any of these ventricles. So this is the picture here. This is the lateral ventricles, and this is the roof of the third ventricle. So let's look at the choroid plexus of the lateral ventricle. As you can see here, the choroid plexus in relation to the crus of the fornix. And as you can see it here in the tila choroidi of the third ventricle here, and in the lateral ventricle here. So this is the foramen of Monroe, and this is the choroid plexus. As you can see, the septal vein, the thalamocyte vein, and the choroidal vein meeting here, and this is the choroid plexus. This is the transfer. This is the sagittal cut of the lateral ventricle. You can see the lateral ventricle here, foramen of Monroe here, and the choroid plexus of the lateral ventricle above, of course, the fornix, and below here is the choroid plexus of the third ventricle. So what is the normal size for neuroimaging? We should be able to recognize the choroid plexus, and we should be able to recognize the normal size of these ones. This is the choroid plexus of the third ventricle and the roof of the third ventricle. And again, the same picture. This introducer is passing through foramen of Monroe. This is the fornix, and you can see the choroid plexus of the third. This is, if you split the fornix, you will see the choroidal plexus in the roof of the third ventricle. As for the choroid plexus of the fourth, it looks like this. Main bulk here, and then extension into the lateral recess of the fourth ventricle. So if you look at it from the front, this is the pons, this is the medulla, then you can see that the main bulk of the choroid plexus runs this way, caudal axial, and then the lateral recess component. Again, choroid plexus of the fourth ventricle extending through the lateral recess outside this way here near the folliculus and the exit of the vagus nerve. Again, choroid plexus of the fourth. This is the main bulk coming from above below and going laterally through the lateral recess. So this is the way it looks, like a fluffy, like cauliflower appearance. And these are actual cuts, pictures from my surgeries to show you how it looks when you look at them during surgery, like this and like this. So if you go microscopic, you would see these papillae of the choroid plexus. And if you look at it again, this is the blood vessel of the choroidal plexus. And then things will pass from the blood vessels into this space, and then it will come through the ependymal lining of the ventricles and then into the CSF. So we're speaking about two barriers: the endothelial blood-brain barrier, and the cerebrospinal fluid barrier, which is very important, especially when you are giving drugs that you need to penetrate into the brain tissue. So the choroid plexus during gestation starts at 6 weeks, and it is completed the growth by 20 weeks. And this is actually a photo of the fetal in utero, 2 weeks in age, and you can see the choroid plexus beginning to show. Again, the appearance of the choroid plexus papillae. So what is the spectrum of the pathology that can affect the choroid plexus? I have two groups, either congenital group or acquired group. Congenital group we'll discuss, and the same thing with acquired group. Starting with congenital, you can have cysts, hyperplasia, Sturge-Weber syndrome, and lipoma of the choroid plexus. So choroid plexus has many pathologies, not only one. These are pictures of choroid plexus cysts. And if you ask any residents of a neurosurgery, what are the cysts of the brain, he must answer you One of them is the choroid plexus cyst, in addition to so many other cysts. Not only arachnoid, there are about 10 types of cysts in the brain. Hyperplasia of the choroid plexus, just hyperplasia. I had many cases referred to me, these cases as tumors, while they are just hyperplasia. This picture of choroid plexus hyperplasia in this infant, and look how much CSF it produces. 2,000 cc per day, which is 5 times the normal. And these people are shunt dependent. You have to put shunt for them. Diffuse villus hyperplasia, again, of the choroid plexus, would produce a lot of CSF. Sturge-Weber syndrome, which, as you know, is the neurocutaneous syndrome, made of port wine stain, leptomeningeal angiomas, and glaucoma, also is associated with choroid plexus hyperplasia. Of course, this is the usual picture of the leptomeningeal angiomas in the Sturge-Weber syndrome, in addition to the port wine stain of the face. Choroid plexus lipoma, congenital. This is leave me alone lesion, don't touch it. The acquired lesions of the choroid plexus are these pathologies we'll discuss in detail. First one is xanthogranuloma. By the definition of the name, xantho means that we have cholesterol cliffs inside associated with lymphocytes and giant cells. Again, I had many of these cases referred to me as tumors. They are not. Plexitis, choroid plexus plexitis in cases of ventriculitis and meningitis, which makes the treatment very difficult. Myelofibrosis, just fibrosis of the choroid plexus. It has nothing to do with the myelofibrosis that we know. Hemorrhage inside the choroid plexus. Again, the patient can present to you with intracranial, intraventricular hemorrhage from the choroid plexus. And last time we discussed the Langerhans cell histocytosis. It can hit the choroid plexus. Tumors, last thing of, please. Yes. All right, thank you very much. Tumors of the choroid plexus. The main ones are the choroid plexus papilloma. It's called the grade 1. Constitutes about 80% of the choroid plexus papillomas, followed by atypical papilloma, 15%, and last is carcinoma, which is only 5%. So the commonest tumor to affect the choroid plexus is the papilloma grade 1, 80%. If you look at the children versus adults, grade 3, the carcinoma is more in children, unfortunately, while the others are mixed between the kids and the adults. So choroid plexus papilloma, first to discuss. Pictures of choroid plexus papilloma could be anywhere in the ventricular system. It is less than 1% of brain tumors. It is one of the most common frequent tumors before 2 years of age. So we asked Dr. Jalil Halzon about your experience in these tumors in infants causing hydrocephalus. Can you tell us, please? Can you come here, please?
I didn't know you want to ask a question about this, but you surprised me. I probably had one or two during my 50 years of service with the Tahir. But we had a group of, I was working with the acute leukemia group B called in the States, and we had so many people that were interested to be referred to. This is when I was doing my residency. But I cannot remember the consequence of all the patients that we had. Thank you for asking me.
That was Dr. Jalil Halzon, our senior pediatrician. Remember that choroid plexus papilloma can disseminate. In spite of it being a benign tumor, it can disseminate. So anything in touch with the CSF can actually have CSF droplets. So choroid plexus papilloma is a rare entity in adults. It's more in children. It is 3% pediatric and 20% first year of life. So 20% of first year of life can have choroid plexus papilloma. Male, female, almost equal. Paper about infantile choroid plexus papilloma. And in this case, it is associated with lots of cysts. So where are the locations for choroid plexus papilloma? Mostly in the lateral ventricle, followed by the fourth and last in the third. 4% could be bilateral. So in infants, it is usually supratentorial. In old age, it is usually infratentorial. In infants, it is lateral ventricle. In old age, it is fourth ventricle. This is one of my patients 20 years ago, this third ventricular choroid plexus papilloma. And this is a paper about unusual location for choroid plexus in the Pioneer region. Again, various sites of these choroid plexus papillomas in the fourth ventricle. It can actually rarely go into the cerebellomontane angle, like our case, which we are going to present today. So this tumor going into the cerebellomontane angle was actually a choroid plexus. And this is proven histologically. This is a paper from USA, 2014. It can be bilateral in the cerebellomontane angle. And this way you would think this is a neurofibromatosis type 2. And this is a case of cerebellomontane angle, choroid plexus papilloma in infant associated with the cysts. So CP angle can be the location for these choroid plexus papillomas. You think this is vestibular schwannoma, meningioma. The commonest lesion in the cerebellomontane angle are vestibular schwannomas, followed by meningiomas, followed by epidermoid. But we forgot about the other lesions. Choroid plexus of the fourth ventricle, in this case, was associated with the pheochromocytoma of the suprarenal gland. Unusual combination. In this particular paper, it was associated with Wilms tumor of the kidney. So this is another strange association. Remember that you can have spinal deposits even in a benign choroid plexus papilloma, as in this case, choroid plexus papilloma is here, and these are the droplets of the lesion. That's why we have to do total spinal MRI for any case in touch with the CSF. You can have metastasis growing into choroid plexus, another tumor that you find here. Again, you think this is papilloma. This was a metastasis. Metastasis can come from colon, from thyroid, from melanoma, from everywhere else. The droplets are more in the carcinoma than the papilloma. So how do they look, the papillomas? CT, isodense on CT with lots of calcification. MRI, they are well demarcated, look like cauliflower as you have seen. Sometimes they have calcification. MRI isotense on T1, hyperintense on T2. In contrast, is highly contrast enhancement because they are very vascular. And this is the telltale of the pathology. This blood vessel giving supply to this choroid plexus papilloma. Whenever you see this, you are sure that this is choroid plexus papilloma. They can be ossified choroid plexus papilloma, like in this case. Choroid plexus papilloma presenting as non-contrast, so not necessarily always with contrast. You can see the variability. And that's why when we discuss, we ask our radiologists to be gracious about describing what is the differential diagnosis of these lesions. It is not enough to describe, but to go into the differential diagnosis. Why this should be a choroid plexus papilloma, why it shouldn't be the other pathology. Angiogram usually show you the single vessel supplying the choroid plexus. Now, this is the second type of choroplexus, the atypical choroplexus. Grade 1 is papilloma, grade 2 is the atypical. And this is a paper about the atypical. Usually there is some brain invasion. And this is another atypical choroplexus papilloma. And this is one case of mine of atypical choroplexus papilloma. You can see clearly the brain invasion. And this is pre-op, this is post-op. Another patient of mine with atypical choroplexus papilloma. He came from Libya, 45-year-old, very vascular, extremely vascular. So we had to do embolization. This is technically challenging. Total tumor visits in young age is very important. Is Dr. Hazim Habib here? Hazim, please. So we ask you to do embolization of this case. Hi, this is Dr. Habib, interventional neuroradiology. This case was presented for us for embolization pre-operative, and this is typical scenario it is still within the debate, but many centers, they adopt the idea of embolization of papillomas before surgery. The most important thing in planning the embolization of choroid plexus papilloma is that, they are supplied by choroidal arteries, mainly either anterior or posterior choroidal arteries. And you have to understand the anatomical variance of the choroidal arteries in particular, from which segments. Usually posterior, they arise from posterior cerebral, but they can arise as well individually from the internal carotid. So in this case, I think we tackled it through the anterior choroidal artery. This is probably the arterial supply of the lesion here. And you can see the blush of the tumor. It's a large tumor. This is the total blush of the tumor. It would look typical like what it is on the CT. So probably this case was supplied from a posterior choroidal artery, and you can see its venous drainage, and this is the tumor supplied by many as well by the posterior cerebral artery circulation and superior cerebellum. So embolization was done, and it should be a very, very slow injection of liquid embolic within the tumor, because you don't need to have any reflux, especially if you are going through the anterior or posterior choroidal. And if you are going through the anterior choroidal, you have to take care of the plexal point. Plexal point is the point where beyond it, you should do the injection, and be proximal to that, it's very, very dangerous to do this. So in here, we can see the cast of the liquid embolic, which is in this case was, I think, the onyx material, filling most of the vascularity of the tumor. And you can see in the late arterial phase and early venous phase, the marked reduction of the vascularity and enhancement of the mass at this stage. So this is a more close-up view of the lesion, and it shows you the a good casting, what we call the volumetric casting of the tumor. Now these are the delayed images. This is the delayed venous phase as well. It shows the reduction in the venous drainage of the tumor. So probably this is like partial embolization, but with large volume of embolization. So this particular atypical choroid plexus papilloma, which was very vascular, we were helped by this embolization. So when I operated, it was still very vascular, but without embolization, it would have been impossible. And this is the picture of the lesion that we removed. This is the papilloma, the atypical papilloma. But look at these embolization material within the blood vessels of the specimen. May I ask Dr. Farid Al-Adham to come over here? Are you here, Farid? And tell us about your experience with the embolization of these vascular lesions, the choroid plexus papillomas?
Thank you, Dr. Ibrahim. This was clearly a very nice case illustration of the embolization. Dr. Hazem did a great, nice embolization of typically a very challenging cases to embolize preoperatively. As Dr. Ibrahim mentioned, these cases are typically younger patients with very small vessels. And most importantly, the supply is a crucial blood vessels that you have to go through. Occlusion of the posterior or anterior choroidal arteries, as we know, can result in hemiparesis. So it's not a minor procedure, or just, and you could recognize you're not treating the tumor, you're just trying to make the surgeon life better. So this case clearly was something that added a big value to the surgeon controlling the extensive vascularity of the tumor. However, it's case-by-case basis. The anatomical variants of these cases are very variable, which blood supply is going there, and all that will determine your risk profile of the procedure, and that will be discussed between you as an interventional neurologist, neuroradiologist, and then neurosurgeon, and together you will decide, well, this worth the risk of going through and embolize this patient, like the illustrated case, which clearly was very nicely done. So my experience with this is based on the fact it has to be really done case-by-case basis on the risk profile of the patients. But this was a very nice illustration of this case.
So with embolization, you can use the onyx, the fluid, or use the particles, depending on your experience and also the cost of the material. But as everybody agrees, you don't take embolization lightly. It has its own complications of the procedure itself and of the dye itself. And this is the case after we remove the tumor. You can see we have done a good job. And this is the embolic material as seen on the CT scan. The third type is the choroid plexus carcinoma. So again, think of choroid plexus not simply as a benign lesions, as so many pathologies, including carcinoma. The experience of St. Jude Children's Hospital in Tennessee over a long period of time, 85 to 87, 14 children, 10%, 10 cases were carcinomas. And the experience of Great Ormond Street in London, 79 to 99, 20 years, 34 cases, 9 were carcinomas. So this is a paper from USA of carcinoma of the choroid plexus. Paper from Italy about choroid plexus carcinoma, recent one, 2021. And a paper from China with this invading the brain parenchyma. So when you see invasion of the brain parenchyma, think of either atypical or carcinoma. Another very fierce appearance of the choroid plexus carcinoma. So there are other tumors that can affect the plexus. We discussed that we have congenital lesions and we have discussed the acquired lesions. The acquired lesions include the tumors like these, the papilloma, the atypical, the carcinoma, but there are other tumors that can hit the choroid plexus. Believe it or not, this was a schwannoma of the choroid plexus. Metastasis can hit the choroid plexus. Paper from Canada, metastasis from thyroid papillary carcinoma, from a neuroblastoma, from melanoma. It can be hit by any metastasis. Metastasis can hit the pituitary, can hit the pineal, can hit anywhere. Teratoma of the choroid plexus coming, and strangely enough from India, 2010, a teratoma of the choroid plexus. My experience with the choroid plexus lesions, the tumors, I have 32 patients, majority of which were papillomas, 28, 2 cases atypical and 2 cases of carcinoma over 30 years of experience. The 28 papillomas were mostly in the lateral ventricle, followed by the fourth, followed by the third. Let's see the cases in the lateral ventricle. This boy came to me in a very bad shape, severe hydrocephalus. He was almost dying because of the pressure. And you can see the correct plexus papilloma. You can see the telltale here, the artery giving rise blood supply to the correct plexus. We operated upon him, and he recovered instantly and literally. And there is nothing there. Another case from Kuwait with this temporal lobe correct plexus papilloma, again excised completely. Of the third ventricle, I showed you one case, and this is another 18-year-old female patient. Of the fourth ventricle, my personal series stands at 10 cases, and these are the 10 cases in the fourth ventricle. All of them. But 4 of these cases were not in the fourth. We were in the cerebello-pontine or cerebello-medullary angle. One of them, correct plexus papilloma. As I said, that's how it looks. And the cerebello-pontine angle, cerebello-medullary angle. This is the spinal cord. This is the medulla. Cerebellum is here. You can see the correct plexus. And this is the spinal accessory, or the spinal root of the accessory nerve. And at the end of the session, you can see all of the cranial nerves: 10th, glossopharyngeal, vagus, accessory, and the hypoglossal. So it also connects this area. Let me show you the video. So again, this is the medulla oblongata. This is the cerebellum being retracted up, and I'm separating the tumor of the spinal accessory from the pica. This is the pica. So correct plexus papilloma, just like epidermal, they just insinuate themselves wherever they have a space. And your duty is to extract them without damaging the surrounding structures. This is the cranial accessory here. Here's some fibers from the vagus. The vascular is expected. Fluffy tumor, vascular tumor, like cauliflower. And here again, splitting it from the pica itself. This is the vertebral artery. And this is the cranial accessory. Here I'm looking for the vagus, which is very important. If you damage it, the patient will either stay on the ventilator for life or have a tracheostomy, which is very serious. So this is a benign lesion, but in a very critical situation, and our duty is to remove it without affecting the neurovascular structures. Again, you can see the pica coming from the vertebral. That's why the shortest lifespan of surgeons are among the neurosurgeons, because every surgery reduces your life by 10 years. Very frightening. You are afraid about your patient's well-being. And this is the blood supply coming to the correct plexus. Look here, this tumor inside the loop of pica. So this is the blood supply here, the final piece. Look at this pica here. If you damage the pica, you damage the patients. So very serious, critical kind of surgery. Medulla oblongata, spinal cord, cerebellum, and removing the tumor. So look at the space the tumor was occupying, and look at these cranial nerves, 12 accessory cranial, accessory spinal, glossopharyngeal, and vagus, all being preserved, preservation of the mica and the structures. So the case for today is a correct plexus patelloma and the posterior fossa. It is in the cerebellomedullary and cerebellopontine. And this, I give the microphone to Dr. Sbeih, my daughter, who is a boarded neurosurgeon.
Hello, can you hear me? Okay, hello,
Yes, we can hear you.
great. Good evening to the online audience and good evening to our live audience. I'm Dr. Sbeih from Jordan, a board certified neurosurgeon, and I will be presenting the case for today. So we have a 17-year-old female patient from Jordan. We have a 17-year-old female patient from Jordan who was admitted almost 1 year ago. She had presented with a 2-year duration of headaches that were exacerbated with noise and were associated with photosensitivity. And 3 months prior to her admission, she started to experience increased headaches with increased intensity, and they started to be associated with nausea and vomitings. And as we all know, these are telltale signs of increased intracranial pressure. She also complained 2 months prior to admission of decreased hearing on the right side, right-sided body weakness, and difficulty swallowing. So these are pointing us towards the direction of the brainstem. Unfortunately, on her past medical history, we knew that she was misdiagnosed with migraine, and she was started on Lamictal. And this is unfortunate, to be honest, that a patient with a brain tumor to be diagnosed with a migraine, but that was the case for this patient. Regarding her physical examination, the important things to be noted that she had cafe au lait spots on her dorsal, on the dorsal aspect. Glasgow Coma scale, as we all know, is not a very precise way to, let's say, give a patient an overall condition. Like she had a brain tumor, she had a weakness, but she had a 15/15 Glasgow Coma scale. This is our patient. And on her examination, she had a right-sided facial weakness that was grade 2 on House-Brackman scale. And when it comes to the House-Brackman scale, reaching level 2 or grade 2, there's a mild dysfunction if we take a very good look at the patient, but starting from grade 3, we can see an obvious asymmetry when the patient is doing facial expressions. So she had a grade 2 with a mild dysfunction of her facial nerve. And just a reminder of who invented the House-Brackman grading system. So this is Dr. William Houseman from the States, I think. And this is Dr. Durald Brackman. And we have this slide here showing that he's on good terms with Dr. Sbeih, with Professor Sbeih. Continuing with the physical examination of the patient, she had cerebellar signs, which also points us towards the direction of the brainstem, posterior fossa, and she had veering to the right when it comes to her gait. As we said before, she had a mild weakness on the right side, so upper and lower right limbs. She had 4/5 power, and these were her labs, fairly normal. And sometimes we order a blood film for our patient, which was normal for this patient. Regarding her images, as we can see here, this is the lesion. This is a cerebellomedullary area, and area it's at an angle. And we can see the tumor here compressing the brainstem and compressing the cerebellum. This is T1 with contrast. We can see the vivid enhancement we mentioned before, and we can see the compression on the medulla and the compression on the cerebellum. Also, T1 with contrast, we can see the enhancement and we can see the compression. And this is a very interesting image because it looks scary when we see the sigmoid and the jugular very prominent, scary because this is the area where we'll be working. But as we will come to know now, it's one of the normal variants where we can see a big jugular bulb here. But we are in very close proximity to it. Again, same finding, looks scary. This is a Fiesta sequence where we do it to really delineate the cranial nerves pathway. This is pica. This is facial and vestibular going into the internal meatus. This is our lesion on the other side, which explains her facial weakness and her right-sided hearing loss. Another image with the trigeminal nerve on the other side, our tumor reaching up to the pons, ABC. And this is the sagittal images showing the lesion here and here and here. And as we said, it's close to the sigmoid and jugular. And this is her angiogram. As we can see the vertebrals here. This is pica, basilar, and we know from, as Dr. Hazem told us, that the tumor was fed by pica. And these are her MRVs. As we know, we ordered them as a baseline for all patients, regardless of the case. We have to know our venous and arterial anatomy beforehand. This is another image, and this is the pica segment, the cortical segment of pica here, showing beautifully. And as Dr. Sbeih said, we do spinal imaging for these patients with these tumors to rule out any drop metastasis, and this patient had none. And this is the CT. As we can see here, the jugular foramen is enlarged, as here, and we can see here, which is a normal variant. When it comes to the differential diagnosis, we've been taught that it's a wide, vast differential diagnosis in each and every case, and this is not a different scenario. And when it comes to the cerebellopontine area or angle, we have a variety of lesions that can come from this area, and we'll come to them one by one. So it can be an ependymoma. It does look a bit like our case here. So this is one of our patients, one of Dr. Sbeih's patients, and she had an ependymoma. Another one that had a pilocytic astrocytoma. Another patient with astrocytoma here. Glioblastoma can come here and can present with these signs, as we have said. Medulloblastoma doesn't always have to be in the midline, it can come in laterally. Medulloblastoma, as in this patient. Hemangioblastoma has a solid component with a cystic component. Meningioma, cerebellopontine meningioma, we can differentiate it from a schwannoma with its white base on the cranium. Histoplasmosis here also. Lymphoma, as we always say, it's one of the differential in all cases. We should always think of lymphoma. Liponeurocytoma, epidermoid and dermoid, they also come in these areas. Metastasis, it's always also in our list in any posterior fossa lesion. Hydatid cyst. A schwannoma of the lower cranial nerves, of the 6th, of the 7th. It can be any of these lesions can also present with the same signs and symptoms, and with almost the same findings on the MRI. Let's not forget the entity, the malignant vestibular schwannoma. This is the patient with showing their pre-op and their post-op images. Endolymphatic sac carcinoma, we usually forget this entity, but it's there. Chondrosarcoma, glomus jugulari, DNET, aneurysms. Of course, we should not forget our vascular entities here. PNET, atypical teratoid, which usually comes in very young patients. Tuberculoma, as in this patient, histopathologically proven. Cholesterol granuloma. And now we'll come to our consultations for this patient. So we first consulted Dr. Ibrahim Saidat, who's an ophthalmologist, and he gave us the feedback of this patient having minimal hyperemia bilaterally, and she had minimal thickening of the nerve fiber layer around both optic discs. Okay, now Dr. Sbeih will take over again. Thank you.
Before we go into consultations, I'd like to hear the opinion of our researchers here. Dr. Hadidi, can you come over and tell us what do you think of this wide differential diagnosis, and why do you think this could be a correct practice papilloma?
Thank you so much. First, the typical imaging for the typical papilloma is very easy to see. But the difficulty when it is atypical or it is carcinoma. When we see this lesion and suspect, you have to look for necrosis, hemorrhage, and if there is heterogeneous appearance for the lesion. Especially if there is a phloboid, it is indicating high vascularity. The other thing is Dr. Ibrahim said that we have to look at the periventricular area if there is edema or invasion for these lesions. The one thing that I want to remember the resident that the traditional teaching is saying that the hydrocephalus in choroid plexus pathologies is due to overproduction of CSF. There is other two entities you have to remember that mechanical obstruction can cause the hydrocephalus and decrease absorption secondary to hemorrhage from the atypical or carcinoma can cause hydrocephalus. Okay? Calcification is not a reliable thing to rely on to differentiate between typical, atypical, and carcinoma, because it can appear in 25% of all things. But if you set a very strong, solid calcification in an intraventricular lesion, you have to think that this was a papilloma and was twisted, and it's one of the causes of the brain stones. We call it a brain stone if it is intraparenchymal or it is intraventricular. So these things which we have to realize. For the differential diagnosis of this location, which is a rare location for choroid plexus tumor, in addition to the suprasellar and intraparenchymal, it can choroid plexus pathology can be very rarely intraparenchymal. But the typical differential, you have to remember AMEN, AMEN. For the common CP angle tumors, A, acoustic neuron, M, meningioma, E, epidermoid, and N for other nerves tumor. This is for the common. For the rare differential diagnosis for this location. Also, it is AMEN, A for aneurysm or arachnoid cyst, M for metastasis, E for ependymoma, and N for other nerve tumors on that. And thank you.
Can you come here? Dr. Atamne, neurologist also.
Okay. We have to differentiate between the papilloma, choroid plexus papilloma, and also the atypical or carcinoma. First of all, you have to look for the invasion, as Dr. Sbeih mentioned that the tumor is invading the parenchyma. Second thing, you have to go to the advance. We have the perfusion, and also we have MRS, اللي هو MR spectroscopy. If we go to the perfusion, almost always the carcinoma have high relative cerebral volume rather than the papilloma or the atypical papilloma. This is fact. The second thing, which is very important, by a spectroscopy. If you go to the spectroscopy for the papilloma, the myoinositol is very high. Myoinositol is metabolite at the 3.5. This is elevated in normal or low-grade gliomas and low in carcinoma. So if you do spectroscopy, the myoinositol is very low. This is very helpful to differentiate between the carcinoma and the papilloma.
Any other opinions of physiologists? So the differential diagnosis is very wide and you have to be careful. Now we come to the consultations. We consulted with Dr. Ibrahim, and obviously he's not here with us today. He is in Dubai collecting money. So he showed some minimal hyperemia of the optic disc. He means there is early pathology. And we consulted because she had decreased hearing with Dr. Mahmoud Al-Assad, ENT surgeon. Mahmoud, are you here? Could you please come over? This patient had decreased hearing on the right side, and Dr. Mahmoud diagnosed hearing loss at 6 kilohertz. Please.
My name is Mahmoud Al-Assad, ENT consultant for the Royal College of Surgeons in Glasgow, UK. Let me see the audiogram. Okay. Well, usually any case of the posterior cranial fossa, Dr. Ibrahim Sbeih, he sent it to me for consultation for the following. First of all, it's for the 7th and 8th cranial nerves, and then for the last 4 cranial nerves. I don't have the audiogram, but there is a right, there is in the right side is mild sensorineural hearing loss at 6 kilohertz, and this is normal. The reflexive in the tympanometry is bilateral, which means that also there is very early 7th cranial nerve affection, as Dr. said, but in reflexes is still there. So this is why we don't consider the reflexes as very early way of detecting the facial nerve palsy, because it has to be the muscles has to be affected properly, so it can be reflexes diminish. And this is what the reflexes means, that we are giving high tone noise to the ear. It goes by the 8th nerve, and it's referred back to the 7th, which affects the stapedial muscle, which is a small muscle in the middle ear. And by that, we can know that the 7th nerve is working or not, but not on the ear stages. For the very mild sensorineural, we can't say that it could be, from the tumor or could be not. So we don't consider this as sign for the cerebellum-pontine angle tumors. We do also examination of nasopharyngoscopy to assist the 10th nerve. So we examine the swallowing and the larynx, and we can detect if there is any early paresis or paralysis of any of the vocal cords. Thank you.
On examination, this patient had some cervical lymph nodes. And I was very alerted that why should this girl have this cervical lymph nodes? And asked my colleague, Dr. Ala Addasi, the oncologist, the hematologist, to see her.
Thank you, Professor Sbeih. Before going into this part, I'll just zip through the differential diagnosis that Professor Sbeih had elegantly summarized, and this is in direct importance to the case in question. Now, these are actual cases of Professor Sbeih. This is not a hypothetical scenario or an exercise in differential diagnoses. This is actually a list of actual cases that masqueraded as our case in the past, and these were the proven pathological diagnoses, right, Professor Sbeih? So one thing to think of is ependymoma, and this is treated in a dramatically different fashion with platinum-based chemotherapy to be followed by radiotherapy that may be extended to involve the craniospinal radiotherapy techniques. Pericytic astrocytoma is the mainstay here is surgical, and in most cases they don't need chemotherapy after it. Astrocytoma grade 2 and low-grade gliomas, they can be treated with chemotherapy or radiotherapy after the event. The mainstay would be radiotherapy, either immediate or delayed, which may be also supported with radiotherapy, with chemotherapy. Accelerator-based mainly. Medulloblastoma is something that is going to be treated dramatically differently. And in medulloblastomas, the mainstay is surgery that can be followed, that should be followed with radiotherapy and platinum-based chemotherapy. It depends upon the subtype of medulloblastoma, of course, but this is an entity that should be treated in a dramatically different fashion. Meningioblastomas, the mainstay is surgery. Meningiomas, the mainstay is surgery, and if they don't get adequate surgery, they're doomed, and radiotherapy is reserved to cases where you want to give this an adjuvant fashion, but the mainstay is adequate surgery. Now, histoplasmosis is something that is noteworthy to stress, because these patients would be treated with antifungals with excellent results, and they won't need anything after that. Lymphoma in this site would be either secondary or primary, and it would be extremely unusual for lymphoma to present with isolated cervical lymph nodes and isolated site of metastasis in the CP angle in this fashion. Having said that, when you see enough of those, you'll see them. And regardless of the subtype of lymphoma, it's of paramount importance to know, is this primary serous lymphoma, or is this a secondary involvement of the parenchyma with a process that involved the lymphoid system elsewhere. And in examination of this patient, there were only isolated cervical lymph nodes that looked reactive in nature and mobile, and there was really no hint of lymphadenopathy elsewhere, and the thyroid examination was also normal. And two things to think of in this fashion if the lymph nodes on exam looked abnormal or worrisome, or had there been evaluation of lymph nodes elsewhere in the body, either by clinical examination or by imaging, it would be of paramount importance to ascertain the diagnosis of lymphoma before embarking with surgery, because if this is a lymphoma and the diagnosis is secondary lymphoma involvement in the CP angle, the treatment is radically different. And treatment of the systemic lymphoma, which would not really touch the parenchymal involvement, and treatment of the CNS part, the parenchymal part, and the mainstay of this is methotrexate at high enough levels. And by that, I mean high dose methotrexate would be classified as anything in excess of 3.5 grams per meter squared and above, that can be given every 2 to 3 weeks, usually every 2 weeks. But frequently regimens that incorporate methotrexate at high enough doses would go as high as 8 grams per meter squared every 2 weeks, of course, with leucovorin rescue. So the major time of the admissions is leucovorin rescue. Again, it would be extremely unusual for this to happen with only shotty lymph nodes. Only the shotty lymph nodes are red herrings, and this is primary CNS lymphoma that would be discovered on pathology. Epidermoid and dermoid, the mainstay is surgery, and metastasis, of course. And this is another thing with the cervical lymph nodes. We want to make sure that these are not cervical lymph nodes that are rising as metastasis from the thyroid, because that would be an explanation for a CP angle lymph node. Now, particularly that these were cervical, not supraclavicular lymph nodes. If these are supraclavicular lymph nodes with a CP angle lesion, you want to make sure that this is not a lung lesion that metastasizes to the brain, or a breast lesion that metastasizes to the brain, or a colon or gastric lesion that metastasizes to the supraclavicular lymph node and then to the brain. Though gastric and colon primaries would be extremely unusual to metastasize to the brain generally, and to this location in particular. Not to mention other cysts and schwannomas that would be treated in a dramatically different manner. So in this particular case, the lymph nodes were not really worrisome, and it would be very hard to have tied the shotty lymph nodes felt in the cervical region, not in the supraclav, with the rest of the covalent scenario. Two things in differential diagnosis that are frequently forgotten: tuberculomas and tuberculosis is frequently forgotten. Hydra cysts are frequently forgotten. We are living in an endemic country for tuberculosis, and this is not really something that should be forgotten. It's something that can definitely involve the cervical lymph nodes as well, though cervical lymph nodes by tuberculoma is usually quite significant and not easy to miss, unless one does not want to examine his patients a priori. Thank you.
Somebody may ask, why should we bother about this differential diagnosis? We will go operate and take the specimen to the histopathology. This time, he will give us an answer. The answer is big no. You have to put this differential diagnosis and discuss it with the patient. In this case, the patient and her parents. I discussed with them whether it is a schwannoma and what's the result. I discussed with them if it is NF1. I discussed with them every possibility of differential diagnosis. So you should know this beforehand. That's why differential diagnosis in the radiology report is mandatory. So Dr. Abdasi took a biopsy of these lymph nodes and there was nothing there. But that was a relief, because I was worried about lymphoma, I was worried about metastasis, I was worried about everything there. May I ask Dr. Ziad Mahadin to come over, please? Dr. Ziad was the initial neurologist who treated her. I must say that he is the one who diagnosed her. When she did not respond to the migraine treatment, he was the one to order the MRI. Ziad, what is the chance of a patient with migraine having a brain treatment?
evening. Dr. Mahadin, I'm a neurologist, I'm a consultant at Ibn al-Haytham Hospital. The chance, she's a female, and a female that comes at this age when she complains of unilateral headache, which is throbbing with photosensitivity, with subnausea. The first thing that crosses your mind is that this patient has migraine. Actually, her presentation was not that long. It was like a month, maybe 6 weeks. So she used to have headaches in the past, but they were sporadic. Then the headaches became more frequent, and they stopped responding to the regular medications. I thought since she's a female, I would give her a medication that she needs to stay on it for the migraine. It wouldn't be having side effects. Like if you give the Dipakine, she would add weight. If you throw max, she might have other problems. However, when we gave her the treatment, then she came and she complained of, I noted the next visit that there was that asymmetry in her face, and she started complaining that the hearing dropped in her ear, and the headache they were not responding to the treatment. So I thought probably there's something wrong. We gave her Imigran, we gave her, initially she said she responded to it, but then she said it didn't work with her that much. Usually, you don't do an MRI for every patient who have migraine, because if it's typical, you don't need to do that. But if the headache is not responding to the medication, then you think that there might be something else. Apart from that, she started complaining of some sensory feeling on the side that after that she became mildly weak with it. Initially, I didn't notice. I did for her the tandem gait. She walked on her toes, heels, everything. There was no drop in her hand. But then when she complained that there was mild weakness on the right side, we thought let's do an MRI. And actually, that's what we did. We did the MRI, and there was the lesion there. The problem with this patient, after 6 months, she was going for her exams, which were the final exams to decide after that to go to the university. And we saw the lesion there. And we thought, does she need to have the surgery now or later on? We consulted with Dr. Ibrahim Sbeih. He said, we cannot wait on it. And we did that. Now, the other question is how frequent you would have a tumor with a migraine? Well, not that much. It's usually there's no association between them. Migraine is common, the tumors are not. But the thing with the patients who have migraine, they sometimes might mislead you, because if you have a tumor on the right side, you would have numbness on the other side or weakness or something. With the migraine, usually most of the patients who pay attention for them, they say they have the headache on the right side or the left side, and they have numbness on the same side with their face or hand, and it goes away, and then the headache comes. It depends on the physical exam. When you notice that something is wrong, there's asymmetry, upgoing plantar, dropping in one hand, or change in hearing on one side, that's when the red flags comes and you don't want to miss something. And actually, we were lucky that we did the MRI soon. Otherwise, we would have like a big lesion going with the problem. But I was checking with her family. They just left because they have to go. Since before she came to me, before we did the MRI, symptoms were that long. They said, no, it was just 6 to 8 weeks. It wasn't like that big. That area in the brain, in the CP angle, actually, it can accommodate a large something before it starts giving symptoms. Same like frontal lobe, where you have a big mass there, before it stops pushing on the olfactory or something, we didn't have symptoms because they're kind, I think, called the silent areas. Okay. Thank you.
So beware of migraine and venous headaches, because sometimes you have to change your plan accordingly. Neurologist, how often do you see brain lesions in patients with migraine? Very well. What's wrong with doing that?
There is no response, there is no symptom, visual symptoms, not whatever.
So you treat the common, which is migraine. If it is not typical, if it's not responding, you go for it. That's correct. So the one who diagnosed it was Dr. Ziad. We saw that she is not responding. He ordered MRI. He referred her to me immediately. Thank you, Dr. Ziad. But please, not more.
Have headache. And this exactly is normal. There's nothing else. You do an MRI, it will be abnormal in probably less than 1% of the cases. So, cost effectiveness, you don't do it unless it's a flag there saying.
Thank you very much. But I did not like you saying if she was a female, that's why you were worried. Are females different creatures?
It's like, you know, it's there. The migraine is more in females. However, the cluster headache is the problem of the males, which is even more severe.
So clustered for males and migraine for females. Thank you, Zee. We consulted Dr. Ibrahim because we decided neurosurgery. Are you here? Because this case do in the sitting position. The sitting position is something that to think of. We made a consent form for the Arabic language if the patient is speaking Arabic, or English language if she is speaking English. In this case, she's Jordanian, so the consent form is in Arabic, detailing everything there is under the sun. And this is the incision, start of the craniotomy. So before we show you the film, let's see the anatomy that we are going to face. This is the sitting position. Patient is in the semi-sitting position. Feet are at the level of the heart to decrease the air embolism. We are very experienced with sitting position. I've done more than 1,000 cases of sitting position. I've never missed one patient for air embolism. Air embolism happens every case, but we detect it and we treat it. So we are not afraid of sitting position, which is so easy to go for. We monitor all the cranial nerves. Monitoring. We use the navigation if necessary. And of course, the microscope, the sitting position. And we go for the suboccipital muscles, the septum of the occipital bone. So this is the suboccipital bone. And this is the craniotomy that you do. And then you will face this sitting position. So this is the right side, right cerebellum, left cerebellum. This is the medulla oblongata. And these are the tonsils of the cerebellum. So you can retract both tonsils. You can go to the vermis, either transvermian or transtillar approach. And you have always to be careful about the pica coming from the vertebra. It has 5 courses: the premedullary, the paramedullary, the tonsil, the cortic. So this is the appearance: right cerebellum, left cerebellum. This is the arachnoid of the cisterna magna. And if you, as I said, take the cerebellum by retracted, you can go into the foot with tilla velum approach. So let me show you still pictures of this case before we show you the video. So sitting position, this is the right side, this is the right cerebellum. We are retracting it up, and this is the tumor. We insert the tumor with the knife and start removing the tumor with the forceps using the ultrasonic aspirator. And then we go laterally, retract the cerebellum medially. We find the 7/8 nerve complex, spatial and vestibulocochlear, separate the tumor from them. And here we can see the superior proposal vein going into the superior proposal sinus. Superior proposal vein is here, 7/8 from here is the tumor. Remember, this is 16, 17-year-old girl. you damage your facial nerve, that would be disaster of your life. So this is 78. This is the branches of mica. This is the tumor. You dissect the tumor from the arachnoid, from the branches of mica, from the 78 complex. Continue dissection. Again, this is the terms of vein. Rotem says that if you damage it, you will cause major cerebellar deficits. Sometimes did take it out without any problem. So careful dissection. So now you can see the 7 and 8. Because the one anterior is the facial, the one posterior is the vestibulocochlear. This is the tumor. Final stages, you can see the labyrinthine artery, branch of mica. Slowly, gently, facial vestibulocochlear, labyrinthine artery, and the tumor. You can see the space the tumor was occupying here. Peter's bone. Continue dissection. So 7, 8. Once again, shows you that the lifespan of a neurosurgeon is short because of the stresses that we face. I am operating with this 16-year-old girl. I'm dealing with her facial. I'm really worried about her. This is the labyrinthine artery. And here you can see the glossopharyngeal vagus and the accessory going to the jugular foramen. And then the final moment when you take the retractor out, cerebellum falls back without being damaged. So we usually record this in 3D, and we give you the 3D glasses, but because we have online audience, we just do 2D. So this is the surgery that you have seen. And still picture, you can now see it in a moving style. Cutting the surface of the tumor, using the ultrasonic aspirator to reduce the volume of the tumor. Slowly, gently, tumor is coming out. Very careful touch fraction of the tumor. Very typical of correct plexus. I knew immediately that this is a correct plexus. Using the ultrasonic aspirator. And then I would put the retractor this way so that I would take the cerebellum medially and go laterally to it. Cutting the arachnoid. And now I'm seeing the 7-8 complex. I'm trying to separate the arachnoid from them. The branches of mica are here. So the frozen there is here. This is life-shortening kind of surgery for the surgeon. And the stages of the tumor removal. Again, if we damage this artery, again should be deaf. So final stages, putting saline, gauche, observing the cavity the tumor occupied. You can see the venous nerve here going to the jugular foramen. And then looking the retractor and cerebellum coming back to its place without swelling, without damage. Histopathology.
أهلا فيكم. My name is Dr. Hussam Farsakh. Can see the process of the choroid plexus is usually really four, as expected. Every one of these are part of the choroid plexus, and these are different morphologies of different tumors. So this was choroid plexus papilloma. I do usually in each case touch imprints, which is cytology, because also I'm bored in cytopathology. I found cytopathology is very helpful when you diagnose it with histopathology. You can see these are the papillae. You can see them usually in clusters, three-dimensional clusters. So I know from the touch imprints that this is choroid plexus papilloma. You can see sometimes some homogeneous bodies, like in papillary carcinoma, and this is some homogeneous bodies, and this is typical. So in the touch imprints, before even I receive the follow section, I know that this is choroid plexus papilloma. And you can see this is very nice, like looks like a tree. This is typical histopathology. Choroid plexus looks like a tree branching. Choroid plexus papilloma. When you go into higher power, you can see the cells. Usually they are overlapping. They are not really atypical. There's minimal atypia or no atypia. There is fibrovascular core, and then the cells branch. When you see this, you can very assured that this is benign, because choroid plexus can be malignant. You can again see how they are branching, and from one branch to another branch, arborizing type of branching. But then you can see the choroid plexus. Usually they are lined by one single layer, usually, and sometimes they are more, but you can see they are ciliated also. They are secreting something. This is the homogeneous bodies, and this is the cells are planned. There's not much difference between one cell and another cell, which gives you assurance this is benign. And there is the fibrovascular core in the middle. Some homogeneous bodies usually can be seen in any papillary tumor. Can be seen in choroid plexus papilloma, can be seen in thyroid papillary carcinoma, can be seen in serous papillary carcinoma of the ovary. But so when you see them, it gives you that this is a papillary tumor, but doesn't tell you what is the origin. And again, you can see this is the glial tissue, or the probably wall of the ventricle, and this is the papillae, and they are plant line cells. More of the tissue, very nice, very fibrovascular core, ciliated. Sometimes it will come condensed and compact, but when you look at the cells, we don't like usually when it is cellular in neuropathology. But when you look at the cells, they are really planned. So we are assured this is benign. Again, here you can see the cilia in the top. This is the wall, fibrous wall attached to it. Some homogeneous bodies, some homogeneous bodies. Some homogeneous bodies usually encircle and different. They are different from calcification that we see, for example, in oligodendroglioma. These are in circles because the different ages of calcification, like the tree that we see. Immunostain in choroid plexus papilloma is usually typical. You can see sometimes positive S100 pancytokeratin. EMA, usually in the lumen of the choroid plexus, they are negative for GFAP as the cells, but you can see the supporting cells, they are positive. They are the framework of the glial tissue. Everything in the brain is usually GFAP, has GFAP positivity, but not the cells itself. Thyroglobulin is negative because there are so many homogeneous bodies. Just want to prove that they are not papillary carcinoma. Usually in papillary carcinoma, thyroglobulin positive, CD99 negative, synaptophysin sometimes can be positive, but in some cells, but it's negative. Ki67 is the proliferation factor, indicating how benign or malignant. The lower the number, the more benign. So usually they are less than 1% in choroid plexus. I just want to show you some immune staining, and we'll finish. This is the pancytokeratin. The brown staining is the positive. So you can see cytokeratin is positive in epithelial or that they have intermediate elements for cytokeratin, and they are positive in the cells but negative in fibrovascular core. This is typical for choroid plexus. Cytokeratin 7 is positive, and cytokeratin 20 is negative, and this is to indicate that this is not from the colon. For example, cytokeratin 19, I found it in one publication in our discovery that cytokeratin 19 is positive in most of the epithelial lesions or cysts in the brain. Almost all of them, cytokeratin 19 is positive because it has some embryological significance. Ki67 is very low, usually is less than 1% of the cells. You can see one positive cell here and one positive cell here and one here, but they are less than 1%. EMA sometimes can be positive and usually in the luminal, at the surface. This is epithelial membrane antigen. It's usually positive in meningioma, but can be positive in epithelial membrane antigen, can be positive in some epithelial cells, but usually in the lumen. GFAP, as I indicated, usually they are positive in the supporting cells. These cells are negative, but this cell is positive. The framework of everything in the brain is GFAP. B63 usually is positive in epithelial regions, but this is negative. And this is, I think, S100, this was positive. You can see positivity, usual nuclear staining positivity. And this is the epithelial carcinoma, or choroid plexus carcinoma, in the contrary, to see how bad is the cells. You can see the cells are really bad and polymorphic. And this is from patients with Ibrahim, Sbeih. And you can see how the cells, they are not bland, they are polymorphic, not rounded, and they don't look like each other. And there is so much polymorphism between the cells. And sometimes mitosis. Choroid plexus carcinoma is a really bad tumor. So in this our case is choroid plexus papilloma. Thank you.
People think of histopathology as luxury. I think of it as mandatory and essential, especially with the immune staining. And for any neurosurgical resident, knowledge of these slides, I can put a slide for you and ask you in the exam, what kind of pathology is this you should know. So post-operatively, this is the picture, CT scan, tumor has been removed completely without any complications. This is with contrast, no complications, no residual tumor. And this is the craniotomy and removal of the bone, putting it back because she's a young girl, you want to give her this cosmetic appearance. Remember, as Dr. Jad said, when he diagnosed her with this tumor, she was about 5-6 months from her final exam to Sbeih, so that she can go to the college. And I stopped her from going to exams. I insisted on doing the surgery, and then she can resume her studies. This is the MRI. Again, notice the one that Dr. Nasir pointed to you, the very prominent jugular valve, which is one of the normal valves. So this valve is different from this one. We were worried that the tumor was sitting here, and we were worried that this tumor might be one of the jugular schwannomas, but it tend to be the choroid plexus papilloma. So the coronal views, no complications, total removal of the tumor. Some people may go for partial resection and then radiotherapy. For me, this is a crime against humanity, which is practiced all over the world. It needs two to dance a tango, yes? So I danced a tango with her. I was so pleased, I was so happy. I saved her life. And you can see the weakness on the right side disappeared completely. Such a young, pleasant young woman. No facial weakness, improved completely. This girl went about a week ago to Budapest to start medical college. And to me, This was a achievement of my life. Winter is coming to Jordan. This is views of winter in Jordan. This is the Black Irish symbol of Jordan. And this is the Monday treatment at the Dead Sea. I hope you all enjoyed the presentation, and we'll take the questions first from the online audience and then come back to you here in the today. John, are you there? John?
Whoop, I'm sorry there.
Yeah, we finished. Do you have any questions from the audience?
Okay, do you want to open up the floor, Dr. Sbeih?
Sir, thank you very much for your presentation. I was very much enjoying, and thank you very much for your team and the time you're giving for us. So I have a question and a little bit doubt. So when we talk about preoperative embolization, am I correctly understand you that you are going from preoperative embolization for every case, or it's kind of selective and individual for different patients? And if you go for preoperative embolization, when do you usually take a patient for surgery after embolization? After 12 hours or 24 hours? Thank you.
Thank you for the question. I would repeat embolization for choroid plexus papilloma. Is it every case or is it selected cases? And how soon you take the patient for surgery after embolization? So the first part of your question, do we do it routinely? The answer is no. We select the cases where we think we need to reduce the blood supply, to reduce the blood loss during surgery. So we don't do embolization for every case. We do it very selectively. The second question, if I do embolization, how soon after? After 48 hours of embolization, maybe 3 days, so that we can not give time for the vessels that were closed to reopen again. So 48 hours, 3 days after embolization. Any other questions?
Yes, I have one more question. When it comes to high vascular tumors like choroid plexus papilloma as well, so how do you manage intraoperatively blood loss? Like what strategy you follow to minimize the blood loss? Are you giving intra-op RBC, or are you giving directly after surgery, or you check the HB intra-op and then you give? So kind of neuroanesthetical questions.
Again, I have to repeat your questions for the sake of the audience here in the auditorium. You're asking me about the management of the blood loss for these vascular tumors. It is mainly surgical. It is mainly the association and cooperation between the surgeon and the anesthetist. It is by observing the blood loss, because you use saline, use suction, etc. So every drop of blood must be called for, and we have to know how much is the blood loss and immediately compensate it. We usually prepare blood, we usually prepare fresh frozen plasma. So surgery, blood replacement of the blood loss.
Thank you so much.
Thank you.
Thank you.
Any other questions?
Okay, more questions from the panel. Don't be shy. You've got a lot of knowledge in this webinar. Okay. Everyone's quiet. Harshad, are you still there? Do you have any questions, Harshad? I think he stepped out.
No problem.
Okay.
There are not many questions from the audience. I have to take questions from the people in the auditorium.
Yes. Okay.
Any questions? Again, no questions from the people in the auditorium. So hereby we finish our presentation, and in 2 weeks' time, on a Wednesday, 2 weeks from now, we'll present intracranial germinomes. Okay, John?
Well, thank you very much, all the participants. This was a great webinar. There's not many on the internet like this, any Zooms where you have so many subspecialists commenting on the case. That's excellent. Thank you all very much. And we'll see you in 2 weeks.
See you in 2 weeks. Thank you very much. Goodbye.
Okay. Very good, Dr. Sbeih. Thank you.
Thank you.
Thank you so much.
Yeah. Dr. Mahmood, thank you. Are you there? You still there? Any of the presenters still there that we can thank personally? And this is a good time to network, Nargiza. Good time to meet people, and they remember your face more than the name. So
Yes. Thank you for the opportunity to be the panelist today. So it.
next time the moderator,
Let's go.
maybe, if you want. Okay, very good. So we'll get ready for the next webinar. Tomorrow we have, okay, for your information, because we're off the air right now, Nargiva. We have a webinar, the Brigham, oh, let me get a better link than that. Hold on, I can get a better link than that. Let me get the actual YouTube notice. Can you see the screen share, Nargiva, or no? Of skull-based surgeons, including Benzu, Louis Borba, Jacques Moret, Jorge Murad, Ali Aziz Sultan from Harvard, Richard Hennell from Jacksonville, Jacques Marcos from Miami, going to actually to Texas next month, Osama El Mefti, Ali Krish, Michael Lawton, Mustafa Boskaya, Roberto Heros. What do you think of that lineup, Nargiza?
Yes, it's giants in neurosurgery, and
Yeah.
I'll try my best to join as fast as I can tomorrow.
Yeah,
because we
it's
have
gonna be
surgery.
tough. Yeah, it's during the day. It might be tough for people that
Mhm.
are working, but you can jump in and watch one or two webcasts, one or two presentations. It's 2 days, so just you can hop in when you want to.
Yes.
Very good. Okay. We're going to
So,
wrap that up, and thanks everybody. Thanks, Nargiza, for coming.
thank you so much. Thank you.
Have a good day.
You-
Bye-bye.